I'm the medical director for the CHT and associated for CME. And thank you for coming. I wanted to kind of kick off this year-long lecture series, kind of alternating Thursdays or whatever today is, for the next full academic year, which will be kind of constituted, for those of you that have seen the overall schedule, by a lot of kind of larger concepts, I think, that relate to education, but simulation in particular, but also kind of some really weedy details of some of our projects and the research that we're attempting to accomplish, and for those of you that really want to get hands-on into some of the simulators, which I think is useful to a certain extent if you're interested just on kind of knowing what they can do and know what they can't do, which is kind of relevant. And for those of you that haven't seen a Prezi, there'll be Fenergan suppositories on the way out. I really want to kind of talk about this simulation kind of as we, I think, currently think of it and understand it, but also some of the kind of natural imperatives of why I think we need to be doing more of this in particularly clinical medicine. And obviously there's the question of why, and is it because all the cool kids are doing it? You know, the high-risk industries like aviation, military, nuclear power, these industries for years have been doing a lot of simulation, and I certainly think that we should be doing it, and that's kind of my argument that I'll set out to argue today. It always comes up, though, is there proof that this works? If so, how much is the bang for your buck? It's obviously a fairly expensive and time-consuming undertaking. And there's a kind of a literature base that's been evolving over the last couple of decades. And some of the folks in the room probably know that literature base better than I do, for sure. But I would suffice it to say that when we talk about engagement, an engaged learner, I think, is a more susceptible learner. And simulation certainly is a powerful tool for engagement. Let's talk a little bit about why that is. But first, let me divert into a couple of definitions and some expectations. First up, when we're talking about simulation, what really do we mean? I think I've talked about simulation from the perspective of computational modeling, having kind of done some geeky work with some computer scientists over the years. So in any particular group, it kind of means different things to different people. And you can see behind me the spectrum of what we're talking about, whether it's computational modeling, whether it's cadaver work, whether it's whole body simulators, animals, actors, or otherwise known as standardized patients sometimes. All of those elements can be part of what constitutes a simulation, which really is for the benefit of a particular learning scenario. All of which have various needs or abilities to really kind of portray reality, if you will, or fidelity. And those issues, I think, for learner needs and expectations are really a kind of a strategic consideration. And if you're building a simulation, you're building an environment where you want to do simulation, I would propose to all of you that be a key kind of construct of how much fidelity or how much reality is enough. One of the recent descriptions and kind of advertisements that I saw recently was for a strategic operations simulation group down in Southern California, and they do a lot of military work, they do a lot of law enforcement work, and they have whole cities built. And they have a kind of a Hollywood quality virtual, body parts that they use, but their goal is to be able to desensitize their people to the point where they can step over body parts that have been exploded or shot or otherwise maimed in a very violent way to get their job done, whether it's being a rescue medic or whether it's being law enforcement or whether it be a special forces military person. That desensitization piece is strategic. You have a head, you have a burnt bone, you have teeth strewn about the floor. That's a high hyper-realism that we typically don't necessarily need or want to portray in our work here. And that's kind of where it comes into emotional engagement, how much is enough just to kind of get your learner to sweat versus an emotional assault, which might be counterproductive to have body parts flowing around for no good reason. Expectations. Expectations both of the learner and I think a teacher sometimes can be our own worst enemy. Ultimately, at the end of the day, what we want to do is create a teachable moment, and we want to create susceptibility to learning. And I think kind of getting your heart rate up, I think in our own experience, anybody that's engaged clinically in an environment, your awareness, your susceptibility, your eagerness plays a lot into how much you remember, and we'll talk a little bit about that more here in a second. But I think we can all reflect on our times in various scenarios where, as I'm boring you here, the death by PowerPoint, which this is not a PowerPoint, and I'm sure it's much more engaging, right, because it swirls and keeps you awake. Yes, there you go. Is that death by PowerPoint is not particularly engaging, and as a result, is not particularly memorable for a lot of people. And at the end of the day, one of the things that we're all contending with as instructors is my daughter's generation, this next generation of learners who arguably are more constituted by folks more comfortable with technology, arguably a shorter attention span. What, squirrel? What? And we obviously have to consider that the apprenticeship model that a lot of us have kind of learned and trained under is somehow perhaps not as practical as it has been in the past. Not scalable in the ways that it has been in the past, certainly for a lot of our learner groups. And I would question sustainability as our clinical imperative has kind of changed over the years. I know clinically in the emergency department, we really have to move the meat, so to speak, and taking time to teach is something that oftentimes is very difficult. So we're moving to, I would argue, C1, sim many before you actually are, touching a patient. And I would point out a few programs around the world where you don't touch patients until you've actually, and this was regardless of your clinical description. The Israelis apparently have a hospital or an entire health system complex where whether you're a paramedic or a nurse, a doc, of any discipline, you basically have to spend time and kind of be pre-credentialed before you can actually go out and engage the folks in the field. As we talk about imperatives, I would say that because of some of these constraints, we certainly are approaching this ethical imperative, but there's also the practical imperative. And I think from where I sit as a faculty member in the School of Medicine and dealing with house officers, largely the idea that there is, this work hour restriction, the prevalence of disease and prevalence of certain procedures, especially these kind of low frequency but high risk procedures. I'm thinking like cricothyrotomy, I'm thinking of a number of different procedures. They're still important to practice, but the prevalence has become so low that being able to get an actual skill set is quite difficult. And so we have this kind of practical imperative, and when we realize that ethically too, there is this concept that as a colleague, one of my Israeli colleagues, who interestingly is a pilot, trained as a pilot, and then went on to become a pediatric intensivist. One of his more recent quotes was that patients need to be protected from all avoidable harm. They're not a commodity for training. I reflect on some of my experiences of the see one, do one, teach one kind of apprenticeship model of my internship, or actually med school career, when my intern said, hey, great, we've got 2 spinal taps we need to do on the wards. He did the first one, showed me my first spinal tap, and then I got to do the second one, which was a complete flail from beginning to end because that particular individual was very delirious, very sick, rolled over on the needle, a lot of things that could have practically been avoided by some hands-on experience absent the patient. All right, let's get into a little bit more about the what's. So just to put a few things in context, the history of this I think is kind of interesting. Obviously the military, the aviation industry, and others have been at this game for a while. The evolution of medical simulation has really been on a steep curve, but only for the last 20 years or so. The Center for Medical Simulation is in Boston. It's a Harvard-affiliated institution, and it's the other CMS, if you will. But they were established in 1994, which really seems very recent. You're probably familiar with the Institute of Medicine report to Err is Human. That came out in '99 with some interesting kind of mandates, if you will. The foot that you'll see here, the timeline, the first full-body simulators, and the Society for Medical Simulation and a dedicated journal, all recently within the past decade. And here's some of the recommendations from the IOM in their report on Err is Human, really with recommendations for team training, mitigation of injury through training, obviously, that's from the school of duh, I suppose, and we should use simulation whenever possible. Just a quick reflection, I think, on a little bit of adult learning theory. I don't want to dig too deeply into that, partly because of my ignorance, but partly because of the general time frame that I've got to deal with. But as we talk about, the impact of kind of the experiential piece on learning, I don't think that we can necessarily overemphasize that. And Kolb's learning cycle kind of blends itself into some of Bloom's taxonomy, which I'm sure most are somewhat familiar with. But here's the iteration that I kind of like a little bit better. And while I can't say that, down in this bottom right-hand corner where you are participating in a discussion, going on to doing a dramatic presentation or simulating a real experience, that at 2 weeks is going to necessarily yield you a 90% recall. I mean, at 2 weeks, my recall is generally 0 on most things anyway. But for kind of proportionality, I like the idea of kind of that as a take-home. And it's nicely summed up by Confucius. I see and I forget, I hear and I remember, I do and I understand. So really the goals, I think, in all of this is safe learning, right? And that means safe for the patient, but also for the learner. But a couple of caveats or things I think we need to consider. One is, for the patient, and it's easy to kind of assume that since there's not a patient involved, that if you kind of, break your mannequin or you break your patient, you can reach in there and fix them a little bit easier than, actually injuring a patient. But to be wary of the fact that you can't be lazy about this, right? I mean, bad practice can lead to bad practice in the sense that bad, practical learning can lead to sloppy habits and bad actual practice. Likewise, for the learner, the safety in the learner, we have to recognize too that there's fear in judgment. I think anybody that has ever taken a driver's test, and your practical driver test, and the guy sitting next to you goes click click, I thought that was a perfect right-hand turn, click click click. There's fear among judgment of your peers. In that context, likewise, obviously the assessment. Some of our local experience is interesting, I think, is we've had an experience of assessing our emergency medicine residents on kind of an annual or periodic basis, and their ability to captain the ship during the code. And what's interesting is a marker for stress. Not only do we have them fill out kind of a self-evaluation and how stressed they were, but their heart rates on average in a non-exertional, just running a code, directing the code, not doing CPR, but having someone do CPR, averaged about 140 beats a minute, which is pretty high, particularly given that the typical emergency medicine resident these days is a triathlete, mountain climber, whatnot. So it can be stressful, and I would say be wary of that. All right, so moving on to a bit of how. Some of the best practices. Now, these are just suggestions, but I think that spending some key strategic time thinking about what it is that you want to teach in this context is really important. Namely, what is it that is going to be highest yield? And that might be absent an environment in a clinical arena that you can actually rely on, or it can just be what the simulators speak well to. Through the course of this year-long endeavor, hopefully people will get a good sense of some of the things that the simulators do really well, and obviously they played a dead person fabulous, or a nearly dead person. The big motivator, I think, for me has been over the years that I feel a little guilty when I'm in the emergency department and there's a great potential learning environment or a learning scenario for somebody, but the patient's just too sick, or the emergency department is just too busy, and we just have to keep moving and moving. I feel better about it when I can kind of say, let's replicate that. We'll reconstruct that, and we'll deconstruct it, if you will, in an educational environment. But that takes some design, and obviously the observation and analytical pieces are key to that as well. But ultimately, being able to formulate a plan going in and teaching from it, I think is all very strategic. And one of the things that I have recently started doing in a lot of these kind of smaller airway sessions that I do, I don't pre-engage, I don't presuppose anything with my learner. I basically have them come in, I introduce them to the simulator, kind of the overall expectations, and then we run a simulation. And I say, treat the simulator like you would a real patient, and go. 9 times out of 10, they're immediately in the game. A few lingerers will have a little bit of resistance, but you see certainly quickly a light bulb, something happens. As soon as a critical vital sign, a parameter, a pulse oximetry, something changes, you can see that disengagement suddenly changes to engagement, a little sweat on the brow or something, and they're in the game and they're participating. That helps me also diagnostically, because I can put them through the paces and then come back and say to myself, okay, they've got this down. I don't need to focus a whole lot of chat time on the stuff that they did really well. I can kind of glance over that, and I can drill down on some of the larger kind of key pitfalls and common issues that arise in some of these kind of critical care scenarios. Just touching on some controversies here. I know that some of them are not so much controversial, but topics of much consideration and consternation and hair pulling and teeth gnashing. There are a certain number of taboos, I would say, in simulation in particular, and one of them is just around death. And I've certainly heard very dogmatically stated that the simulator should never die. So that doesn't replicate life. And I would suggest that simulators often die, but they should die, if they die, strategically. You don't have them die for punitive value. That said, I think that there have been times when, and I think very powerful simulation scenarios are in the context of death, where you do everything right as a provider. Your patient dies, but the actual crux of the learning environment has to do with what you do after that with the other people in the other room that are the family members, the loved ones of that particular patient. Cost versus benefit, I'll touch on that a little bit. Efficiency is a consideration. And I talked to some of my colleagues that would just basically push back against simulation, where they say, I can do what I need to do. I can check my box off as an instructor and say, I'm the instructor of record of this class because I gave that lecture to a room of 250 people. Check, I'm done. But you can't do that 1 to 250 ratio effectively in a simulation environment, because your ratios are much tighter. You have to be 1 to 4, 1 to 6, or something a little bit more hands-on. And that efficiency from a educator perspective is kind of tough. So this is not so much under controversies necessarily, but styles, just for kind of topic of discussion. The play, pause, rewind, replay kind of scenario is something that I will use in the context of things are going horribly awry, right? An angel appears on the scene and stops and pauses the scenario and says, "Why are you killing this patient now?" it's your ability to kind of divert the inevitable disaster, kind of redirect and have them replay it to some other kind of more valuable learning opportunity. In that, likewise, in terms of style, I kind of alluded to this earlier when I was talking about the desensitization piece, but fidelity, as we kind of our collective experience grows with this, there's a lot you can do with moulage and a lot you can do with making a scenario really look real. But it's expensive and it's time consuming, it's messy, and there are cost issues. The sweet spot is finding enough, I think, finding that you've got enough, but not too much. This top picture up here was, and hopefully in the back you can see kind of the expression of the woman kind of over the bed. The simulator is actually a high fidelity simulator, but was sitting there basically turned off. So it was basically a big doll. The whole context was about a cultural barrier where mom, being Spanish speaking only, was very upset about what was going on. She didn't understand, and the communication with, in this case, a medical student was just escalating, and it was just a perfect little vignette of she started getting angry and kind of yelling in Spanish, and he started getting angry and yelling back in slower English, and like none of this helped, but it all escalated perfectly to make the point of understanding the cultural issues, linguistic barriers, etc., in a very kind of low fidelity kind of situation with regards to the simulator. Obviously, much different with regard to the mom being very high fidelity. And then here's one that we developed recently. This is our little vomiting head here. He's not particularly high fidelity for a lot of things, but there's not a whole lot you can do about a big rubber doll to make it hard to see his upper airway and be able to have to suction and do various things that are important for teaching your learner at a particular point. So some examples for those of you that might not have spent a whole lot of time in our center. We've got a lot of different, we've been very lucky in terms of some recent funding to get a fair number of mannequins. We have task trainers of a kind of broad, sweeping range from simulators for central venous access, and spinal tap, and ultrasoundable for both, which is kind of a next generation approach to a lot of invasive procedures to use ultrasound. Here is a kind of more kind of stepwise in complexity, some complex task trainers. The angio simulator here on the right is meant to be able to replicate various scenarios, vascular and otherwise, of coronary vascular, aortic, carotid, various procedural complexities being able to be scaled up and made appropriate for a much more advanced provider, as opposed to, say, an early clinical fellow or somebody like that. Likewise, our Symbionics virtual reality lab trainer there, being able to train for kind of getting your interns ready to do some basic intervention, minimally invasive cholecystectomy things. Kind of lumped into process and small team, I think, are some of the challenges regarding communication among people you know. So in the emergency department, to my thinking, if I'm working with a core group of providers that I know well, I got techs, I have nurses, I have residents, I have other colleagues that are all familiar to me, safely running a resuscitation is different in that context because the communication fundamentally is different. I know who they are, I know their skill set to a certain degree, and I can ask them, say, Kevin, can you do this? Can you we run our airway, a lot of our airway sessions like that. We have pre-hospital providers. Likewise, here's Ricky, kind of fuzzily off in the distance because of my poor iPhone photography skills, being a distraught family member of this poor unfortunate soul who's collapsed. I think that was the day also where Francisco was attempting to rummage through his pockets because he owed him money. So there were a lot of other kind of distractors in that whole thing. More complex process and more complex team. Though you might be aware that for the past several years we've been running in situ code blue. By in situ meaning kind of taking all of our gear and our team and our recording equipment to the individual units in the hospital and actually running a code blue, calling a code blue, very quickly and efficiently debriefing. So we try to get in and out within a half an hour. So that's a challenge logistically in and of itself, and really only use about 20 minutes of staff time. But that's been something I think that as an accommodation, we've been breaking down some barriers and actually making some culture change in the hospital. So much so that we're able to kind of replicate that model more recently, and we're now doing an actual trauma code blue and calling an actual trauma activation, so that the leadership of that whole trauma team stops what they're doing and they come to the emergency department. And this was Monday, right? It was Monday. And I'll highlight in this particular slide some very creative camera placements, little mini cameras. There's another one hiding up here on the right, another one over here on an IV pole, so that these videos can be aggregated and put together. And our model is an accommodation to the time constraints of these in situ trainings has been that we come in and set up quickly, we use a little bit of staff time, we debrief hopefully very quickly to hit some high relevance, very salient points, and then circle back with video and text saying, for example, in situ code blue, here's an example of excellent CPR. Chest compressions, good recoil, good rate, and then here's the CPR that we saw being performed, compare and contrast. Trying to really synthesize that down into a video that's about 5 minutes long is something that Ali has become a master of, and I'm sure he would be happy to share his wisdom and experience with the group. And then finally, some of the health system-wide trainings that we've done in the past have been MCI, so mass casualty kinds of things. This was one where we had a stump, the actual leg lying under here, but the stump, interestingly, was squirting arterial blood. And, we want to stop that arterial squirt. This was a mock of a bombing. I think it was modeled on the Madrid train bombing, but we had 20, 30 patients arriving, various states of injury. So there was a lot of triage, there was a lot of moving people and resources throughout the health system in anticipation of such a surge. All right, so let's talk a little bit about when. As we talk about integration of curriculum and integration into ongoing professional development, I think that when you think about scalability, you start thinking about integration earlier rather than later. All good things, I think. The idea that medicine is changing and technology is evolving quickly enough that you really are confronted with a couple of different things. One is initial skill acquisition, whether it's early in your training, as an early student, or learning a skill that might be new to you, but you've been out of training for 10 or 15 years. And I think a pertinent example is ultrasound. There are a lot of folks that probably missed that train if they trained 10, 15 years ago in kind of the critical care, emergency medicine, maybe even anesthesia, that wasn't part of necessarily the residency training expectations 10 years ago. But now our residents are much better at it than we as faculty supervisors are. So we have the challenge of teaching old dogs new tricks. So the initial skill acquisition, and then there's the skill maintenance, right? How do you keep up on a skill that's infrequently called for, but still very important downstream? Shoulder dystocia, complicated delivery. Any one of a number of your imagination is really the limit. My sense is vote early, vote often. Probably 10 years old is probably a little too early, I suppose. This is my son Daniel. Being one of, I'm sure, the things that he'll talk to his therapist about in the future is not only the harrowing stories over dinner about blood and guts and gore, but also, you know, his early attempts at resuscitations and defibrillation and airway management in his youth. Teaching and assessment, this is just a gratuitous plug for the good Dr. Yao, who is still with us here before he has to run off. Again, emphasizing some of the scalability, you can take a very similar scenario with very few tweaks and take it from an early learner in a kind of pharmacology plus. Here we are doing an induction, and Dr. Yao, I presume, is talking about neuromuscular blockade, as I'm seeing acetylcholine written backwards there on the glass, and then be able to take that same scenario and kind of scale it up. And it looks like his learners are very engaged. Kind of angry face. All right. So where are we doing it? This is just a kind of a gratuitous plug. I left the screenshot small so you don't have to be tortured by our collective ugly mugs. But the Center for Virtual Care, this is just a panorama, if you're not familiar, of some of our holdings. One of our team shots from the Code Blue, myself, John Pierce in surgery, Bill is down here in the corner, Francisco, Joe Barton is our fellowship director for the emergency medicine programs, and Shelley is the CAO for the center. And as any of you probably hopefully know, if you don't, please feel free to reach out to any one of us if you have questions, or particularly if you have questions about access or curriculum design and utilization simulation. We're here and happy to help. Again, if you are interested, eager to think about a particular approach, how to integrate some of these technologies and simulation into a particular curriculum, my plea to you is to start the conversation early so that we can kind of start thinking about what we can do well and what we have to be creative about, or what we actually can't do. Because obviously, having a pale, cool diaphoretic, or a real life rash, simulators don't do dermatology very well, right? So with that, they do play other things very well, as I mentioned, being a dead person, or mostly dead. Just a quick note on some of our fellowships and some of the research projects. This is a quick nod to some of our fellows, two of them are here, Dr. Julie and Dr. Leif, and Dr. Venepal, who's one of our cardiology faculty members, actually, is wrapping up her year with us as a fellow. Fellowships, as they are, as you might be familiar with kind of the usual fellowship scenario, you're either ACGME or non-ACGME. The beauty of a non-ACGME is you kind of get to, build your own story, if you will. And I think historically our fellows have been able to come in and kind of create a pathway and focus of interest that has been specific to them, whether it's a focus on medical student curriculum, whether it's doing projects around ultrasound and simulation or whatnot. So I'd like to think our fellows have had a lot of flexibility, and this is a kind of an open fellowship. And for the faculty members of the School of Nursing, if you have folks that are interested in doing something like this, and basically having this kind of community mentor approach, happy to engage. We have probably, I was just sitting in my office a couple hours ago thinking about the number of projects we have going on. We probably have about a dozen or so projects that are either funded or kind of some state of funding disrepair, but we're still going through by hook or crook and sheer force of will. So there's a lot of little studies and larger projects that we've been rolling out for the past year or so. So there's a lot on our collective plate in terms of research. All right. So simulation, I think, while in the past maybe not controversial, but I think a lot of people have really cast kind of a cynical eye on simulation as, gosh, it's expensive, perhaps inefficient, and you really got to show me the bang for my buck. I think while this talk isn't really about that, and some of the talks later in the lecture series hopefully will touch more on the details of that quandary. What I would suggest is I think it is, regardless, increasingly prevalent and increasingly studied, and it's important, but it's just among a number of different tools, right? We have a lot of different pieces to the armamentarium, whether it's a basic lecture, whether it's home assignment reading, whether it's an online educational experience. Increasingly, we have higher expectations for these kind of hands-on simulation-based experiences. But it's not without expense. This is an expensive endeavor. Some of the simulators run in the $200,000 range, and we're fortunate enough to have quite a handful of them. So my sense on the kind of bang for your buck, if you have kind of a cost per utilization or a fixed cost, the way to kind of get the cost down and bang for your buck is to use it a lot. And my sense is that Francisco and Bill and Ricky and everybody that's in the center are working hard and keeping the place humming. I'd love to see those simulators never be cool down in terms of them just constantly going. So, sorry, Bill. So some of the challenges, something that I like to think of as a challenge, but this is more for kind of the faculty designer of a particular simulation, is just identifying what I would call a trappable risk. It's a quality assurance, it's a patient risk, patient safety issue that you can kind of capture, make kind of concrete in this environment, as opposed to kind of a vague, nebulous notion of you should communicate better, right? Beyond that too, I would say challenges of creating culture of deliberate practice and learning for mastery. Changing culture is hard. And I mean, I don't mean to belittle that, but there's a lot of inertia. And in a big health system, there are a lot of people doing a lot of things. They're very busy. And being able to make it easy for them to adopt and kind of step up their game collectively is a task that requires really a community approach. Again, case in point, the Code Blue training, we've I think made some significant strides in changing culture in that context. When I was a medical resident, an emergency medical resident, I literally was handed a pager on my first day on the MICU, and as the guy had signed out to me, almost forgot to give me the pager, turns around, hands it back to me, and goes, "Oh, I forgot, you're on call for Code Blue. If it goes off, go where it tells you to. Peace." That was my sum total introduction to the code team. And until about 2 years ago, that had been the status. There was, if you took ACLS, they presumed that you could run a code, right? And of course, the fundamental flaw in all of that, I think, is that we have probably the least experienced, most junior people in the room that are supposed to be running the code, namely the second year MICU resident, right? Where you have a room full of experienced nurses in, say, an ICU setting, who are supposed to be taking direction from somebody who doesn't even want to announce their name when they walk in, they're hiding in the corner. So changing some of the process of how we train and recognizing as we go along, being, going eyes wide open into this and saying, gosh, we're seeing these kind of repeated patterns and feeding that into kind of a PDSA kind of QI loop of we're tweaking it, we're assessing it, we're tweaking it some more, I think has been very revealing and accepted very widely. We're still seeing occasionally codes where they're stopping CPR to check a blood pressure. And so we're able to kind of focus our training on some of the specifics that we're seeing. Supporting master skilled faculty. I think that's a no-brainer, I think, for the schools of health. But more specifically, we're really trying to come up with kind of a recognized faculty champion role for the center. The reality is that there are some folks that have kind of grown up as kind of part of the center, Kevin's been with the center forever, and engaged in doing that. We have kind of key go-to people in various departments. Dr. Yao in anesthesia, for example. Emergency medicine is kind of broadly represented, partly through my background, and Dr. Barton's, Julie's, others. But there's real value, I think, in finding a particular person who can be a departmental or a divisional or a champion at some certain level to kind of say to their colleagues on the other side of the fence, saying, this is really valuable, this is important, and let me help you access it, or let me help you kind of design things, and I'm spreading the gospel, so to speak. And I think lastly, we've been very fortunate in terms of institutional endorsement and health system acceptance. Clearly not the case in a lot of systems around the country, but we have a nice center, we have nice resources. I'd like more staff, and work on opportunities. There are many. I, for the sake of time, didn't try to think I would sit here and count all of them. But thinking collectively as we talk about, again, scaling and where we've taken a lot of our focus in the past decade into mini tasks. I'm going to teach someone how to suture. I'm going to teach someone how to put an IV. I'm going to do all of that in the context of a human patient simulator while that patient is crashing and dying. How we can scale that to no longer doing it with, let's just get a bunch of residents and the residents will apportion themselves to, you're a respiratory therapist and you'll be the nurse and you'll be the tech. I don't know how to be a nurse. I don't know how to be a tech necessarily. Those are uncomfortable spots for me. And being able to actually have those people from those roles come and practice how they play, I think is kind of the key to professional education. And this is just a quick screenshot. This scrolls, but I won't bore you with it. Not that you could read it in the back, but there are a lot of things in the simulation courses on the website. And if you are interested in kind of the breadth or depth of some of the current offerings, get a sense of what's going on. And again, if you're interested in developing coursework, I would strongly advise you to not reinvent the wheel. Contact Bill or myself, kind of get a sense of what other people have done, because the culture here certainly is much, just here, great, here's my curriculum, take it and adjust it to your needs. Because changing the programming, changing the details at the end is fairly simple, but starting in the beginning can be kind of laborious. And again, Finnegan Suppositories, Bill has a bag of them, so if you need a little something for the nausea, lay out. But with that, about 10 minutes left, I'll just open it up for questions. Stunned, stupefied silence. Everybody nauseated? A little bit?
I have a question. Is this as good for cognitive learning as it is for psychomotor learning?
It's a great question. So I think of that as kind of a spectrum. Right? When I talk about scalability, the kind of psychometrics of the psychomotor, the hands-on pieces can be really good. Sometimes they can be not great in simulation because ultimately, for the most part, you're dealing with, things that are made of plastic or dead. It could be animal tissue or cadaver tissue or a dummy that may or may not really replicate what you want. I think the real challenge with this is to involve the cognitive piece. And what we've been focusing on, I think, for the most recent history, has been the cognitive piece around not only kind of on-the-fly kind of diagnostic piece, but that communication element. Because as we look more and more literature comes out about root cause assessments of errors and major disasters and sentinel events, it almost always boils down to, I thought you said a milligram of epinephrine, right? It's been those kinds of communications that have been, I think, really eye-opening for the participants. When you have someone, you debrief at the bedside and you say, well, okay, that guy got the wrong dose or the wrong drug or whatnot. No, that's not what I said. Okay, let's replay it and watch it on video. And you go, okay, well maybe I, as the team leader need to be more aware of what I say, and maybe the rest of the team needs to be more really engaged in the sense of, the value of repeating back and kind of that closed loop communication. Okay, I heard a milligram of epinephrine. Are you sure you wanted a milligram of epinephrine?
Yeah,
Oh, no, I said
challenge
a milliliter, or yeah, whatever. So those kinds of opportunities are there, and sometimes they just present themselves, de novo, but sometimes you kind of have to design them in. I would say that in my experience, especially with these kind of monthly little mini sessions or 2-3 hour sessions that I teach for airway management, there are just common pitfalls that I see constantly that I just keep the door open for them, because I kind of want them to fall into that little hole so that I can pull them out of it and point it out.
And to interject, you can use it to integrate into pathophysiology. For example, I do one all the time, probably 6 or 7 times a year on ARDS. And I used to try to teach it in a lecture. You were flipping back and forth with all these PowerPoints. So I developed it where the simulator actually goes into ARDS. And then when we talk about pathophysiology, you get to put all the pieces together in one area, including the way the ventilator's working, to the way the patient's responding, to the way the vital signs are responding, and the way the labs are responding. And you're not flipping back and forth between PowerPoint slides. And so it really helps them put it all together right after they got to engage in the patient deteriorating. So we never resolved it all the way. We stopped in between and then debrief that and talk about the pathophysiology, and then they can go on and treat the patient. So you can integrate it as a cognitive component.
I would say that there are those times, especially when you talk about kind of more complex, and I think where kind of the state of the art or the state of the understanding has been that, gosh, we can do, I think, a bit more with what we have in terms of teaching to a little bit higher standard, both with the hands-on and team training and some of the cognitive elements to a certain extent. The next step along that continuum often has been, or in discussion most recently has been, well, can we use this as a testing environment? And that the suspension of disbelief and the kind of engagement that you get for kind of creating that learner sponge, if you will, I think is real, and I think that a lot of our participants, and maybe this is just anecdotal, but have come back and said, wow, you did that case last week and I saw a real life case and it just helped. 2 weeks later I saw this patient that was just that exact scenario. Oh my gosh, I felt so much better going into that situation.
And were you teaching with that first scenario?
Right, so if you're teaching how to do
were you testing with that first scenario?
No. Well, I'm just saying we'll do a scenario just ostensibly for educational value. We debrief, we discuss, it's all good. But where I think people are interested is to say, for recertification. Say you're practicing your specialty, you're doing your usual clinical thing, and at whatever interval you might have to recertify. Is it 10 years? Is it 15 years? Or it's you want to change a scope of work and you need to kind of certify on a new process. How does simulation feature into that? Is it real enough to really have a high stakes assessment? And that's where people are kind of pulling hair out right now in terms of trying to figure out, could we come back in 10, 15 years? Because right now, in my specialty in emergency medicine, I have a written board and then I have an oral board right after training. So when I get my initial specialty certification, and the oral kind of practicum is I go to a particular hotel in Chicago and I stand outside a hotel room until the instructor leads me in. I sit down and I have a discussion with little stimuli. Here's an x-ray, here's a lab test, blah, 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 blah. And I have to manage multiple patients simultaneously and all that kind of stuff. Very artificial, but very reproducible, right? So the discussion has been recently, could we do this in a simulated environment where instead of saying, and I think this is probably more relevant to somebody who's been out in practice, say, 30 years and they're recertifying, to say, rather than say to your mock orals preceptor, oh, I just intubate a patient. I intubate the patient, I put a chest tube in. Great. Show me that you can still do that. Because I think we probably all met providers who go, yeah, I can still do that. My tremor's not that bad, you know, and they've been in practice for a long time, and maybe they shouldn't be operating. And that all leads into a larger discussion about, you know, patient safety. Other questions? Other comments, Bill? Been all quiet.
Lovely present.
Yes. You like the hand? Great.
I do.
It's glowing.
I always wondered what it was. My sons use it.
What's that?
I always wondered what it was. My sons use it a lot
Prezi?
because that's what they promote in school.
Well, it's online, so you know this. With Prezi, if you haven't done a Prezi presentation, I like it just because you can have a landscape of. If you've got a discussion that's not particularly linear, you can kind of produce a whole landscape and zoom in and out as I attempted to do, hopefully with some.
It's the days of Venus.
I have a question just to get your insights on. So I'm with the PA NTPA program, and we're starting to use a lot more of this, but I think one of the things that we really struggle with or maybe question ourselves with is what's the best use of this technology versus standardized patient encounters or maybe a paper case, small group discussion, and I think it's kind of a gut feeling, or you know, this maybe lends itself better to small group discussion. Is there any literature you could point us to, or any guidelines that would say? Because I noticed your comment: use simulation whenever you can. Well, you know, I think in our program we have a variety of different learners at different levels, which makes it somewhat difficult. And it seems like a lot of the things that we teach do lend themselves to simulation or to the team-based approach or whatever we want to get out of it. We can usually target that somewhat. But you or anyone have insights in helping us make some of those decisions. Sometimes it's based upon what's available at the time, and you know that. Well,
I think some of it too is based on the comfort level of the faculty member that wants to engage in that way. And so when I speak to kind of style points, I mean, there are folks that give phenomenal PowerPoint, you know, and can really engage an audience. And you know, I think of like some of my favorite TED Talks. You know, they're short, they're to the point, they're often very charismatic speakers. We've probably all had little bits of our lives stolen from us by listening to very unengaging speakers that we've had to be there for. My soul is slowly seeping out of my pores. I would suggest that depending on the interest and the skill set of your providers, you can take a very kind of boring but very astute faculty member and put them into a simulation environment and have them be phenomenally engaging. Because ultimately it's not about them, it's about the thing that's going on there. So it makes the simulation come, you know, if the simulation really comes alive and you've got the learners engaged, they can just drop nuggets at the end and say, you know, let me tell you about this case that I built this on. And this is really how it played out. And people, I think, I mean, ultimately the answer is it needs to be the appropriate mix of all of those, I think. I mean, the paper cases, the roundtable discussions, the sharing of experiences and all that kind of stuff. Sometimes just sitting at a table like this and having conversations like that is great and better, and it doesn't lend it, you know, a simulation, you know, taking up time in the Center for Virtual Care doesn't lend itself to that kind of discussion. But ultimately, I think it's incumbent upon the faculty member to really kind of think how best to play this and kind of mixing it up and perhaps starting. I mean, we're increasingly starting some of our early doctoring students. You know, it used to be just third and fourth year students coming into the center, and now we're getting really early ones. And it's kind of cute because they come in and they do a resuscitation by committee, you know, they're like, okay, who wants to shock the patient? Okay, majority rules, let's shock them, you know, and it's not meant to be a high intensity learning, but it's all about, let's remember why we're here. This is exciting, this is kind of medicine. It's not just another textbook chapter that you have to crunch through. So I mean, that's a long-winded way to kind of ramble about it, but I think it's a mixture of all of those.
You know, and sometimes it's a little bit trial and error, at least it has been for us, because I know we've done a couple of cases where we had the simulator there, but really we spent more time just with the group talking, and, you know, so I've kind of second guessed myself, would this have been better just to have a paper case and sit around the table and talk about it? But yet having the simulator there really added to the reality of, okay, there is a patient involved with this. It's not just this hypothetical person that, you know, we're talking about in a paper case.
I would say that one of the mistakes that I have seen as a kind of a theme is giving a lecture next to a simulator. I mean it's a waste of the space in the simulation, and it's not really utilizing the simulator to its capacity. So while there are lots of opportunities to show different kinds of media, Ali has some great flipboard technology that he can pull out on his iPad and go boom, 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 here's some ultrasound, boom, boom. It's very slick, and I would encourage you to reach out to Ali to get his insight on that. But for the most part, let the simulator do the work. And if you find yourself giving a lecture next to the simulator, either the material's inappropriate or there just needs to be a kind of a reassessment of the delivery style.
It takes practice.
Yeah.
When we all started, because I was a lecturer all the time before. When I first started, first ones I did, I lectured. Then you learn to back away a little bit each time.
Well, and as I said, with my kind of airway resuscitation curriculum that I roll out every month or so, if anybody's interested, second Tuesday of the month at 2 p.m., 222 sessions, I typically just throw them into the simulation and then let things kind of evolve and then kind of debrief that and then go on to another one. Kind of minimally lay the rules of the road and then throw them in to kind of just see what transpires.
I think for the most part that's what we've done, and then spent the time, more significant time in the debriefing, which in my opinion was real learning.
Absolutely, it's all about the debriefing. If you give short shrift to the debriefing, you're missing a big opportunity for educational data.
Because just the brief experience creates that teachable moment.
Right. That susceptibility of that. Other thoughts, comments? Ali, Ian, anything else you'd interject?
Something, two things. I saw given courses when I came here. Was talking about, at least for me, so the basic interest like pathophysiology, and it was impressive how the students, and these are the experts, they practice for long years, they engage with that some sort of basic, which is practical actually. But beside the mannequin with the scenario, still they are very, very engaged with that topic. If we translate it into lecture, probably not be so engaged. Second is lectures like usually 50 minutes, which is.
15-minute attention span. Bill fell asleep twice during my lecture.
I wait 2 times. But the scenario, just like that, what you want to give the students is probably 2, 3, maximum 5 messages you can deliver to them and they will use it. A big example, anaphylaxis. So if you took me or anybody to give a lecture about anaphylaxis, they will speak first about the pathophysiology, the causes, the epidemiology, etc. But in fact, the student, they need already 2, 3 messages. Epinephrine concentration, how to do it. And that's yeah, exactly.
Said like a true emergency physician. Absolutely.
Yeah, because actually there's any morbidity or mortality, that's the first problem. And delaying and recognizing the need for intervention for airway, epinephrine, calling for help, communications. Probably that's about it in terms of translating. My limited experience, I don't know about
I agree. And I think building off that and what you were asking about before, there's certain things that simulated scenarios are really amenable to. And that's when you have to have a team coordinate making a diagnosis rapidly, communicate with each other, and accomplish certain tasks. People need to learn how to apply oxygen, do quality chest compressions, bag a patient appropriately, reassess what they're doing, and not miss any major steps. And you know, it works great because our simulators are dead. Though they can occasionally breathe and do other things, they really work well when it comes to major medical events. And that's when it's really good to have a team there doing these sorts of things because they need to learn to coordinate and think on their feet. I think for a lot of other cases where instability and emergent tasks are not really necessary, then the paper case works great. And just sitting around and talking about it, having quality stimuli available, going through everything in one's thought process is very good. But if it doesn't have to be a crisis situation, you don't have to make it work by bringing in the simulator. And then when you integrate actual psychosocial issues, that's when it's really valuable to have a standardized patient. Because even just next to a mannequin that's not even on, having somebody panicking or freaking out or talking about DNR orders can be a really impressive emotional hit. Yeah. So I think for each of those different gradations, there's a type of simulation that's valuable, but they don't always require it.
Yeah, I think that's helpful. Because I think you're right, the ones that have been very successful is when they need to be assessing, making judgments while they're instituting treatments, and it's like, you know, almost the crash scenarios where everything's going on all at once.
And it's helpful for more advanced and experienced learners. I brought in some PharmDs on like their first day and tried to throw them into a resus scenario, and I think one of them started crying, and then I started crying. So that didn't work great, but you have to have that basic knowledge beforehand, otherwise you get startled too early, and that can be a traumatic thing. You know?
Yeah.
Well, and sometimes one of the benefits of the simulation is, as you build them, then you can adapt it for what they're doing in paper. You're kind of stuck with what you wrote.
Yeah.
Yeah.
Right?
Yeah.
So
Right.
when you're doing the simulation, then you have in your background, I can do this very easy
Mm-hmm.
and very basic, or if they get it, we can go over here with it and wrap it up so that way you don't have either people blown away by too much and learn nothing, or be bored and learn nothing.
Yeah.
So that's one thing that is taking the simulation.
They're not mutually exclusive, the simulator versus standardized patient or, you know, actor. This just comes to mind because this is a thing called a cut suit, which is kind of the more recent generation of, you know, the little IV start pads that you can wear, or the little arms that can have a laceration on them, and you can pretend to be a patient and have to be positioned and maybe scream in pain when you know, inject the lidocaine and all that. This is obviously a much more militarized example, but basically this is it's basically internal armor so that nobody gets poked. But as you can see, this is a person that wears this. This is a chest piece and a neck piece, and it goes down to his arms. You can actually do a thoracotomy on these. So this guy is a real life person, just basically biting on an endotracheal tube while they're, you know, doing things, doing cricothyrotomy and whatnot. So this is, here's what more looks like.
This is the outfire suit.
Yes, this is
Fire suit.
That's what
I
I thought.
I love it. This is just kind of heavy section so you can see what's in it, but it also has abdominal viscera and things like that. So these kinds of hybrid simulators are increasingly coming into play, and so you can take advantage both of the you know, oh my gosh, I need to talk to this person and tell him that we're going to take care of him and he's not going to die. We're going to do everything we can to save him, but also do those life-saving pieces. Because right now it's like, okay, pause, time out, swap in something else. You didn't see that. Look over there, oh, squirrel, boop, boop, and you put another picture in
that
there.
man behind the mirror.
Exactly.
They're behind the curtain. Yeah. Okay, great.
Great, well, thank you guys for coming. Please feel free to reach out to myself or Bill or any of us if you'd like further information, and hopefully we'll see you at some of the upcoming lectures.